A major clinical application of echocardiography is the assessment of ventricular systolic function. This is a fundamental part of the standard echocardiographic examination, but is especially important in patients with heart failure and ischemic heart disease. Ejection fraction is the most widely used clinical parameter for evaluating left ventricular systolic function. To calculate ejection fraction, many echocardiographic methods have been proposed, but none have received universal acceptance. Qualitative grades of left ventricular systolic function. Normal ventricular walls thicken during systole, a manifestation of myocardial fiber shortening. Ventricular systolic contraction is accompanied by a reduction in ventricular cavity size and can be qualitatively assessed as normal, reduced, or hyperdynamic. Normally, 60 to 70% of ventricular end diastolic volume is ejected during each cardiac cycle. Ejection fraction of 55% or more is generally considered normal. Ejection fraction between 40 and 55% is considered mildly reduced. Ejection fraction between 30 and 40% is considered moderately reduced. Ejection fraction less than 30% is considered severely reduced. When the ejection fraction exceeds 70%, it is considered to be hyperdynamic. Reduction of left ventricular systolic function can be eyeball estimated to the nearest 5 to 10% by an experienced observer. Qualitative and semi-quantitative measures of left ventricular systolic function. Eyeball estimates of left ventricular ejection fraction are routinely used in clinical practice, but inter-observer variability is high. Modern treatments of some heart conditions can improve ejection fraction, but this improvement could be no more than a few percentage points. Therefore, an accurate method of calculating ejection fraction is very important in clinical practice. An ideal method of calculating ejection fraction should be accurate, reproducible, simple to perform, and applicable to patients both with and without regional asynergy. Calculating the left ventricular ejection fraction with the Takeholz method. The Takeholz method is an old and widely used approach to calculate left ventricular ejection fraction. To use this method, one should obtain left ventricular M-mode measurements at the base of the heart. The American Society of Echocardiography recommends measurement of left ventricular dimensions with the M-mode line perpendicular to the long axis of the heart and immediately distal to the tips of the mitral valve leaflets in the parasternal long axis view. Measurements are taken at end diastole, defined as the beginning of the QRS complex, but preferably using the widest left ventricular cavity diameter, and at end systole, using the narrowest left ventricular cavity diameter. Based on these measurements, the left ventricular systolic and diastolic volumes and the indices of left ventricular systolic function, such as ejection fraction and fractional shortening, can then be performed. In this image, one can see the calculation of left ventricular ejection fraction using the Takeholz method. The interventricular septal wall thickness at diastole, the left ventricular internal diameter at end diastole, the posterior wall thickness at diastole, the interventricular septal wall thickness at systole, the left ventricular internal diameter at systole, the posterior wall thickness at systole. The apparatus software has automatically calculated left ventricular ejection fraction and fractional shortening. The parameters are 76% and 45% respectively. Estimates of left ventricular volumes and ejection fraction by M mode rely on geometrical assumptions of left ventricular morphology. In Teicholz's method, the calculation of left ventricular volumes is based on M mode measurements, and by using these volumes, ejection fraction can be calculated. However, this method is only recommended when ventricular geometry is relatively normal. In no case should one use the Teicholz method when there is a regional wall motion abnormality. A common pitfall of M-mode measurements is the non-perpendicular alignment of the M-mode line in relation to the long axis of the left ventricle. This leads to overestimation of ventricular dimensions and, as a result, poorly calculated left ventricular volumes. In real practice, the heart's orientation rarely allows one to align the M-mode line exactly perpendicular to the long axis of the left ventricle. Another challenge is to accurately identify the endocardial and epicardial borders and avoid confusion with the contiguous structures, for example chordae, trabeculations, near the posterior wall, and false tendons. In most clinical situations, one cannot use the Teicholz method to calculate left ventricular ejection fraction. Calculating the left ventricular ejection fraction with the modified Simpson's method, method of discs. Two-dimensional echocardiography is the primary modality used for qualitative and quantitative assessment of ventricular systolic performance. Volumetric estimates of left ventricular volumes by two-dimensional echocardiography are based on different geometric methods that combine measurements of left ventricular dimensions and area to calculate volume. When volumetric methods are used in calculating ejection fraction, one should perform manual tracing of endocardial borders at end systole and at end diastole. The biplane method of discs, or modified Simpson's method, is recommended by the American Society of Echocardiography and the European Association of Echocardiography for the calculation of left ventricular ejection fraction. This method does not assume a predetermined geometry of the left ventricle, but instead defines the left ventricular geometry following manual tracing of the acquired left ventricular cavity borders. The left ventricular volume is then quantified by assuming that the left ventricular cavity is a stack of elliptical discs whose volumes are quantified and summated. To calculate the ejection fraction using modified Simpson's method, one should first obtain a high-quality cineloop of the apical four-chamber view. Using the cineloop, one should find the maximal left ventricular diastolic dimension. After activating the appropriate program, one should perform manual tracing of endocardial borders. One is determining the long axis of the left ventricle in diastole. One should return to cineloop and find the minimal dimension of the left ventricle in systole. Again, after activating the appropriate program, one should perform manual tracing of endocardial borders. One is determining the long axis of the left ventricle in systole. One should return to two-dimensional mode and obtain a high-quality cineloop of the apical two-chamber view. Using this cineloop, one should find the maximal left ventricular diastolic dimension. Again, after activating the appropriate program, one should perform manual tracing of endocardial borders. One is determining the long axis of the left ventricle in diastole. One should return to cineloop and find minimal dimension of the left ventricle in systole. Again, After activating the appropriate program, one should perform manual tracing of endocardial borders. One is determining the long axis of the left ventricle in systole. To calculate the ejection fraction with the modified Simpson's method, one needs to obtain two orthogonal views, the apical forechamber and the apical two-chamber. After manual tracing of endocardial borders at end systole and at end diastole, automated software divides the left ventricle into a stack of discs oriented perpendicular to the long axis of the ventricle. Automated software calculates the volume of each individual disc and adds the volumes of all 20 discs. This is performed in systole and in diastole. From the end diastolic frames, the end diastolic volume is calculated. From the end systolic frames, the end systolic volume is calculated. When the volumes are determined, the formula provides ejection fraction. In this image, one can see the calculation of left ventricular ejection fraction using the modified Simpson's method. Apical forechamber view. One obtains the Sinaloop. Using this Sinaloop, one finds the maximal left ventricular diastolic dimension. After activating the appropriate program, one performs manual tracing of endocardial borders. One determines the long axis of the left ventricle in diastole. One returns to the Sinaloop and finds minimal dimension of the left ventricle in systole. Again, after activating the appropriate program, one performs manual tracing of endocardial borders. One determines the long axis of the left ventricle in systole. One returns to two-dimensional mode and obtains a high-quality Sinaloop of apical two-chamber view. Using the Sinaloop, one finds the maximal left ventricular diastolic dimension. By activating the appropriate program, one performs manual tracing of endocardial borders. One determines the long axis of the left ventricle in diastole. One returns to Sinaloop and finds minimal dimension of the left ventricle in systole. Again, after activating the appropriate program, one performs manual tracing of endocardial borders. One determines the long axis of the left ventricle in systole. The calculated ejection fraction is 61%. The advantage of the modified Simpson's method over other volumetric methods is that it takes no assumptions about ventricular geometry. The disadvantage of this method is that considerable sonographer experience is required, as images must be optimized and endocardial borders accurately identified. Simpson's method can also be compromised by poor endocardial border definition in many patients. The method is also time-consuming, and any flaw in one's technique can compromise it. It should be noted that in real clinical practice, one is able to accurately identify endocardial borders in apical views in less than 50% of patients. Thus, it is absolutely necessary to use additional techniques such as harmonic imaging and contrast agents. Two-dimensional echocardiography is not a true tomographic technique, for example such as cardiac computed tomography or cardiac magnetic resonance imaging. Off-axis measurements such as foreshortening easily occur, and as a result, the method accuracy is compromised. Both the reliability of volumetric methods, including the modified Simpson's method, and the reproducibility of obtained parameters of ejection fraction are low and inadequate for clinicians. From our experience, the modified Simpson's method has a tendency to underestimate ejection fraction. Proper patient positioning helps to optimize imaging of parasternal and apical views. Images are best acquired at end expiration or during quiet respiration. Doppler method of calculating left ventricular ejection fraction. The Doppler method of calculating left ventricular ejection fraction is a combined approach using two-dimensional cardiography for calculating left ventricular end diastolic volume and a Doppler for calculating left ventricular stroke volume. First, one measures left ventricular end diastolic diameter on the parasternal long axis view. One executes this on a two-dimensional image using the Sinaloop function. Then, on the same parasternal long axis view, one measures the outflow tract diameter at the base of the aortic leaflets. Using the 5-chamber view, one obtains the pulsed Doppler velocity time integral. The sample volume is positioned at the level of the aortic leaflets. After obtaining the Doppler velocity time integral, one measures its maximal velocity v and duration t. The Darius formula calculates the stroke volume of the left ventricle. Please look at the adapted table for calculation of the stroke volume. For example, the outflow tract diameter at the base of the aortic leaflets is 1.9 centimeters. Maximal velocity of the aortic systolic flow is 1.2 meters per second, and the duration of the systolic flow is 32 hundredths of a second. The left ventricular stroke volume, thus, in this patient is 74 milliliters. The Takeholz formula calculates the left ventricular end diastolic volume. Please look at the appropriate table for calculating the left ventricular end diastolic volume. In our example, the left ventricular end diastolic diameter of 4.9 centimeters corresponds to the left ventricular end diastolic volume of 113 milliliters. Using a nomogram, one obtains the ejection fraction in this particular patient. The ejection fraction is 65%. In this image, one can see the calculation of the left ventricular ejection fraction using the Doppler method. Using the Sinaloop function, one measures the left ventricular end diastolic diameter. This parameter is 4.9 centimeters. By using the Sinaloop function again, one measures the outflow tract diameter at the base of the aortic leaflets. One obtains a 5-chamber view and places the pulsed Doppler sample volume at the level of aortic leaflets. The pulsed Doppler velocity integral is obtained. One measures systolic flow duration, which is 32 hundredths of a second, and its maximal velocity, which is 1.2 meters per second. Left ventricular stroke volume is 74 milliliters. Left ventricular end diastolic volume is 113 milliliters. Thus, the ejection fraction is 65%. The Doppler method of calculating left ventricular ejection fraction is simple, reproducible, and applicable to most patients in clinical practice. It can be easily incorporated into a routine echocardiographic examination. All necessary measurements are performed online rather than derived from time-consuming offline analysis. The Doppler method combines Doppler-derived stroke volume with left ventricular diastolic volume by two-dimensional echocardiography to calculate ejection fraction. It has the potential advantages of being quantitative, relatively simple to do, and relatively independent of left ventricular geometry. The diastolic left ventricular volume with this method is calculated by the Teicholz formula because this measurement is usually much more easily obtained and less time-consuming than with volumetric endocardiographic methods, which rely on drawing contours in the apical views. The Teicholz formula might not be reliable in patients with ventricular asynergy, but conceptually localized distortions of left ventricular geometry should be most pronounced in systole and minimal during diastole when the ventricle assumes an ellipsoidal shape. So the calculation of left ventricular diastolic volume with the Teicholz formula gives reliable measurements in patients both with and without asynergy. The only exceptions are patients with obvious left ventricular aneurysms, where the distortion in left ventricular geometry persists during diastole. When the left ventricular systolic function falls, one sees two opposite phenomena: the increase of the end diastolic volume and decrease of the stroke volume. With the Doppler method, one directly calculates stroke volume by Doppler and end diastolic volume by two-dimensional echocardiography. Thus, with falling left ventricular contractility, the accuracy of calculation of ejection fraction increases. In the Darius formula of stroke volume calculation, the diameter of the aorta is squared, so this parameter should be measured very carefully. In patients with obvious left ventricular aneurysms, the distortion in left ventricular geometry remains in systole and diastole. Therefore, the Teicholz formula is not a reliable method for calculating left ventricular diastolic volume in such patients. One of the limitations of this method is unreliable results in patients with small left ventricles, or when the diastolic dimension is less than 45 millimeters. This is of no significance in the case of smaller ventricles, since ejection fractions in these cases are invariably normal and the Doppler method consistently provides an overestimation which is of little clinical relevance. In patients with mitral regurgitation, results with the Doppler method should be interpreted with caution because, conceptually, the Doppler method is not applicable in patients with significant mitral regurgitation. Regional left ventricular wall motion assessment. Regional left ventricular wall motion assessment generally employs the 16-segment model recommended by the American Society of Echocardiography. A segment that shows noticeable reduction in contractility is hypokinetic. A segment that barely moves or thickens during systole is akinetic. Dyskinetic myocardium moves paradoxically during systole. Aneurysmal myocardium remains deformed during diastole. It should be noted that regional wall motion abnormality is not always associated with reduced ejection fraction. For example, after acute myocardial infarction, the hypokinetic or akinetic segments could be compensated by viable hyperkinetic segments. Regional wall motion assessment is heavily influenced by image quality. Restricted septal movement can be mistaken for septal hypokinesis or akinesis. Apparent hypokinesis of the septum can be seen following any surgery that breaches the pericardium. Closer observation of the septum will often show normal systolic thickening in the absence of true ischemic injury. Paradoxical septal motion in the presence of otherwise normal septal myocardium is seen in right ventricle pressure and volume overload states. In this picture, one can see the segments of the left ventricle which are visible in the parasternal long axis view. Basal anteroseptal, mid-anteroseptal, apical septal, apical lateral, mid-posterior, basal posterior. In this picture, one can see the segments of the left ventricle which are visible in the short axis view at mitral valve level. Basal anteroseptal, basal septal, basal inferior, basal posterior, basal lateral, basal anterior. In this picture, one can see the segments of the left ventricle which are visible in the short axis view at papillary muscle level. Mid-anteroseptal, mid-septal, mid-inferior, mid-posterior, mid-lateral, mid-anterior. In this picture, one can see the segments of the left ventricle which are visible in the short axis view at apex level. Apical septal, apical inferior, apical lateral, apical anterior. In this picture, one can see the segments of the left ventricle which are visible in the apical four-chamber view. Basal septal, mid-septal, apical septal, apical lateral, mid-lateral, basal lateral. In this picture, one can see the segments of the left ventricle which are visible in the apical two-chamber view. Basal inferior, mid-inferior, apical inferior, apical anterior, mid-anterior, basal anterior. Clinical cases. In the first clinical case, we present patient B, who was referred for bypass surgery. The parasternal long axis view. One can see regional left ventricular wall motion abnormalities which are shown in the picture. Now, by slowing the video, one can easily see the regional wall motion. The left ventricular contractility in real time. The short axis view at the mitral valve level. The wall motion abnormalities are shown in this picture. Slowed video. The left ventricular contractility in real time. The short axis view at papillary muscle level. The wall motion abnormalities are shown in the picture. Slowed video. The left ventricular contractility in real time. The short axis view at the apex level. The wall motion abnormalities are shown in the picture. Slowed video. The left ventricular contractility in real time. The apical four-chamber view. The wall motion abnormalities are shown in the picture. Slowed video. The left ventricular contractility in real time. The apical two-chamber view. The motion abnormalities are shown in the picture. Slowed video. The left ventricular contractility in real time. The calculation of left ventricular ejection fraction by using the modified Simpson's method. Manual tracing of endocardial borders in diastole. The long axis view of the left ventricle in diastole. Manual tracing of endocardial borders in systole. The long axis view of the left ventricle in systole. The apical two-chamber view. Manual tracing of endocardial borders in diastole. The long axis view of the left ventricle in diastole. Manual tracing of endocardial borders in systole. The long axis view of the left ventricle in systole. The calculated left ventricular ejection fraction is 36.7%. Calculating ejection fraction using the Doppler method. Determining left ventricular diastolic dimension. It is 5.3 centimeters. Determining outflow tract diameter at the base of the aortic leaflets. It is 2.1 centimeters. Pulsed Doppler velocity time integral at the level of the aortic valves. The flow duration is 24/100ths of a second. Maximal velocity of the flow is 0.9 meters per second. The left ventricular stroke volume is 51 milliliters. The left ventricular end diastolic volume is 135 milliliters. The ejection fraction is 37%. In the second clinical case, we present patient S, who has a history of acute myocardial infarction. The parasternal long axis view. The wall motion abnormalities are shown in the picture. Slowed video. The left ventricular contractility in real time. The short axis view at mitral valve level. The wall motion abnormalities are shown in the picture. Slowed video. The left ventricular contractility in real time. The short axis view at papillary muscle level. The wall motion abnormalities are shown in the picture. Slowed video. The left ventricular contractility in real time. The short axis view at apex level. The wall motion abnormalities are shown in the picture. Slowed video. The left ventricular contractility in real time. The apical four-chamber view. The wall motion abnormalities are shown in the picture. Slowed video. The left ventricular contractility in real time. The apical two-chamber view. The wall motion abnormalities are shown in the picture. Slowed video. The left ventricular contractility in real time. Calculating ejection fraction with the Doppler method. The left ventricular diastolic dimension is 4.8 centimeters. The outflow tract diameter at the base of the aortic leaflets is 2 centimeters. The systolic flow duration is 27/100 of a second. The maximal velocity of the flow is 1.2 meters per second. The left ventricular stroke volume is 70 milliliters. The left ventricular end diastolic volume is 108 milliliters. The ejection fraction thus is 65%. In the third clinical case, we present patient C. The echocardiographic examination of this patient has been technically difficult. The parasternal long axis view. One can see the global reduction of the left ventricular contractility. Slowed video. The left ventricular contractility in real time. The short axis view at mitral valve level. The global reduction of the left ventricular contractility. Slowed video. The left ventricular contractility in real time. The short axis view at papillary muscle level. The global reduction of the left ventricular contractility. Slowed video. The left ventricular contractility in real time. The short axis view at apex level. The mild global reduction of the left ventricular contractility. Slowed video. The left ventricular contractility in real time. We could not obtain acceptable apical views in this patient. Calculating ejection fraction using the Doppler method. The left ventricular diastolic dimension is 6.2 centimeters. The outflow tract diameter at the base of the aortic leaflets is 2.1 centimeters. We were lucky to obtain the pulse Doppler velocity time integral at the level of the aortic valves. The maximal velocity is 0.74 meters per second. The flow duration is 28 hundredths of a second. The stroke volume is 47 milliliters. The left ventricular end diastolic volume is 194 milliliters. Thus, the ejection fraction is 25%.